So the topic is what was new in immune checkpoint inhibitor used in breast cancer? What were the main things that came in this SABCS conference? Yeah. So I have tried to divide my topic into neoadjuvant versus adjuvant and metastatic. Now the first take-home message for a neoadjuvant is immune oncology drug or an immune checkpoint inhibitor are here to stay. Now, these are the 4 pivotal studies. Whenever if there are students, there are sitting, when you talk about neoadjuvant immune checkpoint inhibitor, there are 4 trials that has been conducted, which needs to be discussed. But I will concentrate on the most important study, which was updated, which included pembrolizumab. Please see the number of the patient, 1,174. Though by far the biggest studies in the neoadjuvant setting and adjuvant setting, and there were updates, and it was heartening to see the final outcome. So what was the update? There were an event-free survival sensitivity and subgroup analysis of Keynote 522, which combined neoadjuvant pembro with chemo versus placebo with chemo. So newly diagnosed triple-negative breast cancer, a high risk. Please remember the chemotherapy arm which was taken in both. So it included platins plus Taxol followed by AC, and AC was not dosed then. Please remember platins because that is where one of the advantages is. Combined with pembro followed by pembro post of 9 cycles. The primary endpoint was pathological CR and event-free survival with secondary endpoint what was mentioned above. Now when you look into the first primary endpoint, 14% improvement in terms of absolute number in pathological CR. When you look into PD-L1 positive on the right side and a negative, the quantum of benefit remains more or less the same. So around 14 to 18% improvement in pathological CR when you combine immuno. Now, what was heartening, and I think the most important thing is the secondary endpoint. 2-year cutoff, there was no improvement in event-free survival. But when you look into the 3rd-year cutoff, there was an absolute gain of 7.7. You discuss about Catherine 11. 7.7 is a significant number with 37% reduction in event when you gave pembro in neoadjuvant followed by adjuvant. Now, most important thing and a question that arose was what about patient who achieved pathological CR and patient who did not achieve? Now, if you see in both the arms, those patient who achieved a pathological CR, 92.5% versus 94.4%. So whether you really require adjuvant pembro because you have achieved a pathological CR and in both the arms, the overall survival is 92.5 and 94. So that is a question that is unanswered. But if you have not achieved a pathological CR, giving it in the adjuvant setting, again increase your pathological CR, the event-free survival by more than 10%. So 56.8 versus 67.4. So yes, you should give it in an adjuvant setting if you don't want to give a capacitabine. In terms of nodal analysis, the quantum of benefit in node positive is more, but the important takeaway is in both the subset, node positive, node negative, the pembrolizumab gives a substantial improvement in pathological CR. When you talk about event-free survival in staging, again you see stage 2, 88.6, stage 3, 71.8. So there was a statistically significant improvement in event-free survival irrespective of stage 2 and stage 3. When you look into local recurrence, again lesser. And when you look into distance recurrence, again lesser when you give pembro. So it works in both ways, potentiating your local as well as reducing your systemic recurrence. Now, when we talk about overall survival, again it is at 3 years. But if you look into HR, 0.51 to 1.02, just reaching, but still it was not statistically significant. But I think we should wait for a year or 2 to see whether it really improved the overall survival. But please remember the 2 of the endpoint, which was primary pathological CR, event-free survival, both improved, and this was a positive study. So based on this study, July 27, 2021, FDA has approved pembrolizumab in high-risk early TNBC as neoadjuvant followed by adjuvant. Now comes the important question that I took out from the debate discussion. Do you really require a IO therapy in a adjuvant setting? Because if you look into those patients in durvalumab, if you remember your JAPAR-NEVO study, it included only neoadjuvant arm. And if you look into 3-year overall survival, it was 85.6. And when you look into pembro, it is 84.5. Again, these are cross-trial comparison, but something that we need to understand, how long to give pembro. If you have achieved a pathological ER, really you should give your pembro in a adjuvant setting or not. Looking into adverse event, one more important is discontinuation rate was 27.7, which is quite high. 1 in 4 discontinued combination of chemo with immuno, However, when you talk about immuno as a culprit, it is 10% only. So probably, yes, there is some things to say that tolerance-wise, 1 in 4 discontinued is a slightly bigger number. Why did Keynote 522 succeed? You remember your NeoTrip PD-L1 study? Probably that study failed and we don't have, because this is the most important thing they discussed, which is the ideal partner to be combined with IOs or a chemo checkpoint inhibitor. So the two best drugs are platin, cisplatin, and doxorubicin. And if you remember in this study, platins were also included and doxorubicin was included with IO arm. Of course, you need to debate, but the data suggests that these are the one of best drugs which you should combine with IO to get a good immune response, as has been studied in the ISPY2 also. So the first take-home message from the neoadjuvant, and that was takeaway from this SABCS, was Keynote 522 regime improved event-free survival by 7.7% in high-risk TNBC and has become a standard of care. 3 questions that we keep on discussing is, in all IO benefit is conferred by neoadjuvant administration, or you really require a adjuvant IO also? How do you reconcile or combine with standard of care capecitabine? We remember our CREATE study. Or how do you combine it with oraparib in germline mutation? I would like you to remember that there is a synergism between PARP inhibitor and IO, as seen in metastatic studying. Remember your Mediola and Tepesio study. So yes, probably in future you may have a data or trial which may combine both. And the last thing is, which is the best drug to be combined with IO? Should be a taxane, should be a platin, should be a anthracycline. Now comes to the second part. What was a takeaway from the SABCS 2021 setting? So 2 pivotal studies here. Now this was in summary. Again, if there is any students who are sitting, if you have to discuss metastatic, these are the 3 pivotal studies, but the update came in the most important study again was a Keynote 355, which was a Pembro study which combined with Pecli or a NAB-Pecli or a Gem-Carbo. So these were the recommendations that they give. All patients in metastatic TNBC should be tested for PD-L1, TMB, and MSI. All patients who are candidates for immunotherapy should have a tumor tissue tested for PD-L1, at least one, irrespective of the prior therapy. You should not test your PD-L1 in the early stage breast cancer. And for me, this was more important. At what site you should do a biopsy for testing PD-L1 is, it should not be liver. Please remember, extrahepatic, because PD-L1 positivity on liver tissue was less than 20% versus 63% when you take primary breast as a tissue. And at least once you should test your NGS or PD-L1, and probably the best time it at first relapse. So the pivotal study 355 was again untreated TNBC or recurrent at least 6 months after Pembro with chemo versus chemo only. And here there was subgroup analysis of 1 to 9, 10 to 19, and more than 20. So if you remember, around 55% it was combined with Gem-Carbo, and in 45 either a Pecli, which would be NAB, or a Dino or Pecli tested. Around 38% of the patient totally had a CPS of more than 10. Now, when you look into the first subset analysis, PD-L1 of more than 10%, there was a reduction in the risk of death by around 27%. Absolute gain of 6.9 nearly months, 7 months, and it reached 23. Now, when you look into PD-L1 CPS more than 1 or intent to treat, please remember, it has cross-unity hazard ratio 1.05, 1.2. So all the benefit which was there was driven by those with a CPS of more than 10. So no improvement. Now, this is most important. What in 10 to 19 and more than 20? When you look into hazard ratio 0.71 and 0.72. So yes, the quantum of benefit or the benefit of immuno came in those with a PD-L1 of more than 10. What about less than 1 to 9, 0.97 and 1.09? So no use of giving this drug in CPS less than 10. Now, when you look into PFS, again, benefit in all the 3 subsets. But again, I will like you to remember that this was driven again by those with a CPS of more than 10. Now, again, when you look into the update, 10 to 19 and more than 20, 0.71 and 0.62. Again, the quantum of benefit is more if your PD-L1 by CPS is more. And if you look into less than 1 and 1 to 9, 1.09 and 0.85. Again, reiterating that all patients should not be given and it should be CPS more than 10. Look into adverse effect. Discontinuation rate is 18.3% and grade 3 to 5 are 68%. But more importantly, what was immune-related adverse event? So led to discontinuation is only 2.8 and grade 3 to 5 was 5.3. If you remember your Atizo trial of IM patient 130 and 131, it was 10%. So probably in metastatic grade 3 to 5, adverse events were lesser as compared to the Atizo trial. So the take-home message from this trial was that there was meaningful improvement in PFS and OS versus chemo in those with a CPS of more than 10. CPS more than 10 is a reasonable cutoff to define a population who are likely to benefit with pembro plus chemo. Safety profile was consistent. The second study and the last part of my presentation is what is the TMB in which you should use your combination of IO plus IO. If you remember your keynote 158, which was a main study, TMB more than 10 should be taken irrespective of which solid tumor you are taking. You can give your immune checkpoint, but it is not the way. Probably this is a better sophistication. So multiply treated patient with metastatic HER2/neu, TMB of more than 9, combined, this was a phase 2, so a single arm Nivo plus Ipi till progression. Now, if you look into it, the main primary endpoint was response rate. Secondary endpoint, I would like you to remember ORR and TMB more than 14, which was a pre-specified secondary endpoint with PFS, clinical benefit rate, and safety. 30 patients, 5 patients had a TMB of more than 14, and 25 had 9 to 14. Now, when you look into the response rate, only 5 responded out of 30. And the clinical benefit rate, if you see, it was only 5. So what are these 5 patients are most important? Out of these 5, 3 patients had TMB of more than 14. So if you look into it, out of 5, 3 responded with the response rate of 60%. Now, when you look into the survival in these 5 patients, the progression-free survival is 9.5 months. The overall survival is not reached. When you look into the toxicities, again, only 3 patients had grade 3 toxicity. So toxicity was consistent as we have seen in other IO, and there was no grade 4 to 5 adverse event. So what did this trial suggest? High TMB, if you say overall, it was only 16.7. If you remember your TAPOR, it was 21. But the most important thing they suggested, probably 9 is not the way, or 10, it should be 14, because patient with TMB of more than 14 mutations were a minority, but they achieved the overall response rate of 60%, and further work is needed to investigate which is the optimal TMB for selecting patient on ICI therapy. So probably this is something, this was interesting and was one of the most talked about trial in this SABCS. So I have summarized my metastatic in a single slide. How do I treat my patient in a TNBC in a metastatic setting? This is according to FDA. Locally recurrent metastatic TNBC with PDL1 of CPS more than 10. And if it is second or third line, all MSI high or deficient MMR or TMB high solid tumor with progression on viral line. And please remember, atezolizumab has been withdrawn from the market for this indication. Even the Indian authorities have told them not to promote atezolizumab in this indication. So the 2 indications where you should remember, you should think of, and the pembro is the only drug you should think of giving in your TNBC. I thank you all. There were 3 updates, which were probably one of the major, lot of posters, which I don't think so carried any good message till now. I again thank Dr. Rahul, Dr. Vivek, and Tarun for this kind invitation. Thank you all.